Dear distinguished guests, colleagues, to our attendees in person and online, welcome to the Center for Global Development, and thank you for tuning in to our event, Assistive Technology, Shaping the Global Market and the Path Forward. My name is Jubilee Ahazi, and I'm a research assistant here at CGD on the Global Health Policy team. CGD is a nonpartisan think tank that works to reduce global poverty and improve the lives through innovative economic research that drives better policy and practice by the world's top decision makers. Our health team has a long established work on cost effectiveness, market shaping, and procurement, but often with regards to HIV/AIDS, TB, malaria, and other domains. Today, I am excited to discuss this important topic on the global market for assistive technologies, to highlight some of the challenges in the market, tools that can help to improve it, and opportunities for targeted policy interventions in this domain. For a bit of context, assistive technology is an umbrella term for assistive products such as wheelchairs, hearing aids, prostheses, eyeglasses, or digital devices. AT supports individuals in multiple ways by helping individuals participate in education, the labor market, and civic life while also improving an individual's independence and overall well-being. However, there is a huge unmet global need for AT, particularly in low and middle income countries. For example, over 1 billion people need at least one form of AT, but over 90% do not have access. In regard to workforce shortages, countries with the highest prevalence of disability-related health conditions have the lowest supply of health workers in provision of assistive technologies. Market barriers put a strain on access to AT with regards to high costs, lack of availability and awareness, and limited financing and trained personnel. Our event today will follow a hybrid format with a few attendees in person and the majority of you online. The program for today is as follows. First, an intervention by Pascal Bijou-Lavelle, CEO of AT Scale, to introduce the AT market landscape and describe the AT Scale Global Partnership. This will be followed by an expert panel discussion moderated by CGD Senior Fellow Prashant Yadav. There will be an opportunity to field questions from the audience both in person and online, and then we'll wrap up with closing statements. Questions can be typed into the comment section on YouTube or feel free to tag us on Twitter at CGDev. I am more than pleased to welcome to the stage Pascal Bijou-Lavelle. Over to you.
Thank you, Jubilee. Thank you, Prashant. Thank you to the Center for Global Development. It's really great to be here today and talk about assistive technology, which is not something that happens enough in the global health arena. So this is really a great opportunity. As Jubilee mentioned, I'm Pascal Bijou-Lavelle. I head up AT Scale, the Global Partnership for Assistive Technology. She kind of stole my opening line by giving away what AT actually is, because I was going to ask you, how many of you actually use assistive technology in your own day-to-day lives? And maybe some of you would have been wondering, well, I'm not quite sure actually, because I'm not sure what AT is. And that's the reality, right? Most people use one form of assistive technology or another without actually knowing it. Eyeglasses, for example, but hearing aids, or wheelchairs, or using closed caption on your smartphone, or magnifying the script on your smartphone. That's all forms of assistive technology. Actually, the latest numbers show that from the WHO and UNICEF that 2.5 billion people across the world need one form of assistive technology or another. And that's probably an underestimate. Now, of course, that includes eyeglasses. If you exclude eyeglasses, then the number is closer to about 1 billion assistive technology. That number is growing rapidly, and we expect it to grow to 3.5 billion by 2050. And that's due to aging populations, the growing incidence of non-communicable diseases, and so on. But where it really hurts, and again, Jubilee mentioned this, is that there's this massive inequity between access to assistive technology here in high-income countries where we're speaking from versus lower-income countries. Again, we may take it for granted here in the US or in Europe that we can walk down to a corner store and get a pair of eyeglasses, or that if we do need a wheelchair, we can access one and it's covered by a health insurance scheme or another form of support. Sadly, that's not the case in many parts of the world. And in low-income countries, often as few as 10% of people have access to AT. If you think about the Sustainable Development Goals, there's no way we can reach the Sustainable Development Goals if we don't achieve inclusion. And there's no way we can achieve inclusion if we don't have assistive technology. How does one attend school if one can't see the blackboard or hear the teacher, for example? So increasing access to AT is not just the right thing to do, but it's also a smart thing to do. And we've demonstrated that there's actually a $9 to $1 return on investment. For every dollar that we invest in AT, there's a $9 return to society, to the economy, because now children are able to finish school. More people are able to get a job. Caregivers don't have to dedicate 100% of their time taking care of a loved one who might have an impairment. And all of that adds up then to a real return in measurable terms. So what's holding us back? And I know I shouldn't take too much time, and we have a lot to talk about, but stigma is still out there. Lack of awareness is a major issue. Financing is lacking at all levels. Human resources and the lack of it from healthcare workers, but social workers as well. The products, while products exist, they're often not affordable or not adapted to lower resource settings. And we're basically seeing a market failure, and we'll talk more about that today. So AT Scale was set up to try to address all of these challenges. We've got an ambitious goal to try to reach 500 million more people by 2030 with life-changing assistive technology. AT Scale is a partnership. We're hosted by the UN in Geneva, by UN Ops. We're a partnership that brings together technical expertise through partners like WHO and UNICEF and others. We bring together civil society and organizations of people living with disabilities. We bring together donor governments and partner governments from lower income countries. And we bring together the private sector as well, because we can't advance this agenda without all of the stakeholders being around the table. We're also a fund. We mobilize resources that we then pool and aim to apply to do one of three things. One is address those market barriers, the systems barriers that exist in countries, policies that need to be adapted, supply chain systems that need to be strengthened, human resources that need to be trained, health insurance schemes that need to be introduced, products that need to be adapted, and so on and so forth. That's one. Secondly, market shaping. So we're trying to also look at how we can influence market dynamics to have a more sustainable impact towards greater access. And thirdly, advocacy and raising the flag. That's one of the things I'm doing today, is talking about this, because not enough people talk about it. There's no awareness that this is actually an issue. And we need to really generate a lot more momentum around assistive technology. We need to grow this partnership. And that's one of the reasons why I'm excited about the dialogue today. We really want to bring on new players around the table that can help advance the thinking, help advance product innovation, help advance our financing needs, and bring the different sectors together. Today, you are probably all from the health sector, but this is actually a real cross-cutting issue. It's about education, it's about the labor market, it's about health, it's about social welfare. It really is a cross-cutting thing, which is why it's so important and critical, but it's also why it's been a challenge, because oftentimes things that are cross-cutting fall through the cracks. Nobody feels responsible for it. And so we're going to change that. Last but not least, what we really need in this space is sort of a new Bill Gates. What Gates did, for example, to vaccines in 23 years ago, actually, in the year 2000, when he put $800 million on the table, and that really changed the world from an immunization perspective. What we need is that. We need a big, bold move to really do a game-changing effect on assistive technology. So I hope that this conversation today will help get that ball rolling and help us reach that goal of 500 million more people by 2030. Thanks, Prashant. Thanks.
Thank you, Pascal. My name is Prashant Yadav. I want to add to Jubilee's welcome. Welcome everyone to the Center for Global Development. I think, like Pascal said, our interest in this comes from the intersectionality of what AT does in education, in health, in gender, and we'll get into some, as you start looking at data that's more granular. So it cuts across many different areas of work here at CGD. I think it's fair to say that as we've examined how do health technologies get to people in low and middle income countries, this has been a cornerstone of CGD's health team's work over the past many years, and one particular body of work, which was around triple transition and procurement, reminded us that a lot has to happen from a product, a health technology, being at the factory gate ready, adapted for a population till it can actually get to the beneficiaries or patients. And we've identified what those barriers are. We've created frameworks for understanding them. And I think there are many such frameworks that exist which talk about what does access mean, what are affordability barriers, what are availability barriers, how do we ensure adaptability better, and so on. But I think one part that we've taken away from that is that there has to be a good architecture on top of all of this, because sometimes we face very complex trade-offs in the sense that if you want to ensure affordability, then maybe availability goes down. If you want to ensure availability, sometimes affordability is not best met. And so when you have these complex trade-offs, what is the architecture, both at the global supranational level, at the national level, that helps solve these problems? And I think we found, as we did some little exploration in AT, we found that that's an interesting area here. We haven't seen much work on what the architecture should be like. And the partnership that you lead, Pascal, is at least an attempt to get us closer to that architecture. But before I start, I want to do two things. First is, I think our thoughts are with people who've suffered loss of life to their family in Turkey and Syria due to the horrible tragedy in the earthquake. And I think it's also a somber reminder to us that in addition to the lives lost, over time, as we get the rescue and search and rescue operations out, AT will be needed for taking care of people and keeping them having a good quality of life for their well-being, the nature of permanent disability. So I think it's a somber reminder about both what this event is about, what the need for AT in the world is, but at the same time, we want to make sure we keep all the people impacted there in our thoughts and prayers. Second, I want to introduce our esteemed panel here. We have great panelists. Two of them are here with us in person. 3 are joining remotely. So let me start. Pascal, you heard from. Pascal is the CEO of the AT Scale Partnership. Next to Pascal here at CGD is Andrea Figel. Andrea is the CEO of the Health Finance Institute. They do a lot of work on health financing. Then I have Michael Stein. He's a professor at Harvard Law School and at Harvard Medical School and works extensively on disability. We have Bo Thompson. He's the vice president of this particular initiative and Children at Play at the Lego Foundation, which is working on children's development in many different dimensions, but this is another area of their work. And then last but not least, we have Christopher Gandrup Moreno, who heads innovation at UNICEF. So 5 very interesting and diverse perspectives on our panel. I want to start by going back to Pascal first. The last time I've worked with you was when you were leading the UN Commission on Life-Saving Commodities. There was a great framework to look at what are the key market shortcomings, which included demand-side issues, supply-side issues. It didn't probably look at awareness, stigma, and some of the other things that you highlighted. But as you reflect on AT now, that is your new role, and where you've come from, or vaccines, for example, you were at Gavi for many years. Do you think there are similarities in the way we think about access to vaccines, access to the life-saving products in the UN Commission, and AT, or is AT very different? And if yes, what dimensions do you think AT is different? Explain to us the nuances here, which we ought to keep in mind as we start with our discussion.
Yeah. No, thanks, Prashant. And I think there are indeed a lot of, well, there's some similarities, of course, but also some quite stark differences that I'm really seeing as we tackle this problem. I mean, the life-saving commodities, there were many of them, if you remember, and some of them were quite niche, and that is something that I remember was a challenge at the time, especially when you're thinking about sort of influencing markets and so forth, because when you don't have large volumes, it's difficult to really create a significant shift from a market perspective. And this is one of the key differences that we're seeing with assistive technology versus vaccines or ARVs or other products and medicines, is that lack of market. Basically, there is no mature market for assistive technology in lower resource settings. Christopher, who will be speaking shortly, probably argues that there is no market actually in many of these places for assistive technology, and that's part of the problem, right? So we're really starting from a very low starting point relative to some of the other issues we've tried to tackle over the years. So we're really talking more about market building than market shaping at this point in time. That emphasis on creating demand is much more important in this space, also because of stigma issues and so forth that maybe is less important in some other health areas. And so I think some of the tools that exist maybe are not necessarily as relevant. It's not easy to secure volume guarantees for AT, for example, a tool that has been used very effectively in many other areas. So we do have to try to think creatively about what other mechanisms can we use to really incentivize that market.
Excellent. And we'll come back to this, Pascal, but I think it'll be useful for us to understand when we say there isn't a mature market, or if Christopher says there is no market, is it largely because of a lack of a systematic payment architecture? Is it more because of awareness, or where between awareness versus payment architecture do you put the two things? And I understand it is both. So getting a little bit more nuanced and deeper into this will help us progress this conversation, and we'll also come back to Andre on that. But let me go to Christophe, since Pascal said, Christophe, your claim is there is no market. And at UNICEF, outside of the work specifically on disability, you all work with a variety of health technologies. Many of them you've contributed by looking at cost effectiveness. How should a national purchaser make a choice, providing them better prices through your catalog pricing, supply divisions work, right? A whole range of tools that work with a very diverse set of health technologies, from malaria RDTs to complex oxygen equipment to, baby warmer types of products. So does AT is very diverse. We are clubbing lots of things in a single umbrella term here, but does AT fit neatly in your boxes? Does AT fall out of your standard categorization? And if it does, similar to the question to Pascal, are there structural things that you believe are different in the AT market? And also tell us a little bit more about what is UNICEF doing in AT? What is the current state of programming that exists?
Yeah, thank you. Maybe sort of as a framework to note that, as we said, I'm heading up innovation right now. I'm actually also heading up all of our medical procurement, so double heading for quite a few months here. And as part of that, I lead sort of our emerging areas. So that's within oxygen, newborn, maternal, and also the AT space. So not just sort of the single product focus, but also broad areas where there hasn't hasn't yet been appropriate uptake in the markets or in the countries that we normally support. And I think certainly to sort of the other products you mentioned there, just sort of in passing, there is a huge difference. So malaria diagnostics, or vaccines, or some of these very established areas. Whereas if I compare AT to many of the things that I sit with responsibility of, so these I just mentioned, you see a lot of similarities in this sense that there is no market. And I think it's really important to point out here what we mean by market. So normally when we in this space talk about the market, we mean the supply side, whereas if you talk about the market from a sort of private sector perspective, you mean the demand side. So we mean the supply side here in this sector, and if you're a private company, you mean the demand side when you talk about the market. And the point here is that there isn't really any demand, or it's extremely low, at least what comes from governments and established institutions. There might be some that's bought by communities, by individuals themselves directly, that sort of goes outside of us, but that's hard for us to keep a view of. And in these areas where this is what we're seeing, and we're sort of building it up, we have very few tools to play with, as Pascal said. The normal endeavors of trying to structure market guarantees, of various intelligent buying, working in a structured way with large-scale programming, just doesn't work if there isn't any funding. And there really isn't any donor funding to go in and buy at scale. And the idea is often that we want the governments to step in themselves and buy, but that doesn't happen, at least not when we're talking true low resource or true low income countries. The higher up you go on that income curve, the more you see that, of course. And I think it's important as a part of that to really distinguish there, right? So if you go up markets or go up to middle income countries, let's say, then it starts being some very different dynamics. Some of the differences that we do see from the other areas is sort of these issues around that AT is a permanent thing, right? So many of the other things we deal with is a one-off, so oxygen, newborn, maternal, what have you. It's a one-off treatment, whereas AT is a lifetime thing. And that then in turn closely relates to higher complexity around the service provisioning. So you really need it to be there, right? Without that, it doesn't often matter whether the product is there. For many products, such a wheelchair, you might actually do more harm than good if you have the product there, but not appropriate service provisioning. And ensuring you're building that up often also happens from scratch. So you, to a less degree than the other areas, tap into the established infrastructure. So you're really building everything from scratch in these environments. I also think one of the things we often don't talk a lot about, Pascal touched on it, but is that when we're looking at normal health interventions, we're typically talking efficiency from sort of a value from dollar perspective. How many lives can you save via an intervention? Whereas in the AT space, sort of simplified put, you're more talking about return on investment, because you're talking about ensuring that this person, for example, can see and therefore they can learn and become a valued member of society, rather than operating at the edge of society, and in many societies, unfortunately, being perceived as a liability. So we should be looking at it in a different way. To the question of what UNICEF is doing, so in lack of any procurement and implementation power at scale, we are trying to the best of our ability, to build the foundation, and we're doing that sort of through three core ways, and these are all happening very much hand in hand with at scale and the other partners we work with. Actually, to a full degree, one might argue. So we've decided to put a series of products in the catalog. So we started with hearing aids and wheelchair, and now we're adding incontinence and vision and one more product. And we're selecting those where we think we can make most difference. In hearing, we've managed to get price down from plus 2,000 to 140 or so. So a drastic price decrease. We saw a huge percentage increase in throughput. So from, I think it was 1,200 to 5,000 hearing aids. But of course, in absolute numbers, this is extremely small numbers, right? But we are seeing a bit of pickup. So we're creating that as a foundation for driving demand. So we know that that matters in terms of enabling donors, governments, via donors, with donor money, to put money against these areas and start buying. And in turn, through that, we then also ensure that what they're buying is quality products, so they get the best value for money in making these endeavors. Then we have sort of the broad programming advocacy activities to highlight the importance of it. And then last, but one might argue, most importantly, we're trying to aid, as was said in the beginning, governments in making quality decisions around these areas. So we're trying to support them in figuring out what makes sense and not, depending on where they're at, the issues they've got, the resources they're dealing with, and then create pilots that proves what's possible. We have built and will be investing a lot more in that, creating a decision support tool that we've had huge success with in other areas, most noticeably in oxygen, but also in newborn, some emergencies, which aids to ensure that you can have a quality dialogue with governments around what AT you should buy and what it would cost, etc. So we're trying all together to lay that foundation for things to happen as part of moving it up. But want to emphasize everything Pascal said in terms of, until we've got the serious resources moving into the space, it will be sort of laying that foundation to in the most efficient way, ensure we can move once things really start picking up. And then, of course, hopefully while doing that, we help individual people in creating it.
Thanks, Christoph. Two things and follow up before we go to Bo. One is when we say there isn't a market, there is no systematic purchasing, we are referring to the fact that there is a large intrinsic demand, and the only portion of that is getting translated into actual purchases is either out-of-pocket payment by the individual or donations and small volume charity, things like that. And is there a large systematic, at least for eyeglasses, we hear about companies doing CSR programs to get the bigger eyeglasses companies doing CSR programs to get eyeglasses out. So is that a fair characterization of out-of-pocket, charity donation, and some CSR? That's the only market. There isn't much of a government purchasing market yet. Yes?
Yep, that's correct. And I think, the term that you could use is there isn't any funded demand.
Okay.
Right.
And Christoph, are the products well adapted for use in LMICs?
Just to follow up on the other one, so we put a lot of emphasis these years in making a difference between need and demand, right? So the need is huge. The demand, as Pascal is saying, is small. And it's very important to differentiate between these two. Both to not diminish the need as well as to not associate need with demand. And then to your second question, so as we've done in most other areas, we try to not, I'm chief of innovation, as I often say, but we try to avoid innovation at all costs, right? So we really try to pick up what's out there as a first stance and then get the learnings with those before we start driving the next generations. So there's certainly a need for more adaptable product. There always is. But innovation is complex, it's expensive, it takes time. And we much prefer to invest the scarce resources we've got in this space to ensure that there's access to the best possible products out there, and then use that as a foundation for learn and figure out, okay, what are those next-gen products that are needed? As Sustainer, we're aiming in our space, right, for commoditized products, so stuff that's highly proven, extremely cheap, and that tends to not be the newest. So our push in general, with exceptions, will be to try to pick up the most suitable that's out there and then really try to get pricing down as much as humanly possible on that. And then with a long view to see where there's those things rather than sort of having innovation come first. There's always a huge need for local, as I said, the service provisioning part, which is sort of, one might argue there's quite a bit of adoption, innovation there. But it is in how you fit sort of the global procurement angle is by and large of the established products.
And maybe if I can add, Prashant, just on that, because of this lack of funded demand, there isn't an incentive for manufacturers to adapt their products to these markets. And in fact, they have a counter incentive driven by the high income markets to do increasingly complex, high-tech, costly AT, because that's what makes them more competitive in high income markets, right? And so we have to find a way, and we don't have the right solution yet, I think, but to create more incentive to get them to look at those lower resource setting markets as the markets of the future.
Great. We'll go to Bo Thompson from the Lego Foundation. Bo, first of all, thanks for joining us. when people think of the Lego Foundation, and I'm acknowledging my limited knowledge, I think I would think of it as, well, children, play, learning, child development, child education, right? Those are the first things that come to mind when I think about the Lego Foundation. So tell us more about, how does access to assistive technology fit in your foundation's overall grant making? What drove you to think about assistive technology as a priority area? What is your logic model of your grant making? What changes will it bring? Is it recurrent? Will it create long-term sustainability so that it's not going to require grant making in the future? How have you thought about it? And also explain some of your current partners and your evolving partner landscape in this area.
Absolutely. Thank you for having me. And the keywords you brought up about the Lego Foundation absolutely resonate. So even it might not be the most recognized foundation right now, we are right now the biggest funder of education and assistive technologies. Broadly speaking, inclusion more specifically is at the core of our strategy and our work. And that includes to empower all children to be equipped with knowledge and skills, and a breadth of different skills. And what it requires is that we transform systems to take into account much more the joyful and engaging benefits of play. We do that partly in the most desperate situations by supporting humanitarian work, migrations after war and crisis and displacement and refugee camps. But we also do that in transforming systems to look at quality education through play. And I think the operating mechanism here is that when children learn, they do that best about the world and themselves through engaging with their senses, by interacting, feeling, touching the world. And that require that they have the means to be able to engage, even if they have any form of ability that they can't engage with. So we need a kind of optimistic ways of thinking about play for their cognitive and their social and physical development, and also the emotional confidence for these groups to grow and develop and learn. So when we think about assistive technologies, it can be for us any kind of material that increase and expand the capabilities, not necessarily toys in itself, but anything that level the playing ground for them to participate, and not necessarily Lego bricks. Even that's an example I'll just use right now. So one example is David Aguilar. He has Poland syndrome, which means he is prevented from using his right arm. At the age of 9, he started to develop a fully functional prosthetic arm using Lego bricks. So he literally built like a new device for his arm, so he could continue to kind of grasp things and move around. And through several iterations, he adapted it. It led to a Guinness World Record. He led to educational programs, and he also participated in innovations to develop new types of Lego pieces for others to participate in robotics. And I think I'm saying this because it's not only about these immediate capabilities you get with the new products and services, but that you think about materials and tools that enable children and young people to have that form of agency and the support that they can actually create and adapt while they interact with the world. So it's a little bit beyond the particular product in itself, but more as platforms for assistive technology. So part of our work is really to highlight these examples of individuals who not only innovate, but also helps to overcome the stigma that is around special needs areas. So one area now that is growing for us is we then say, what can we do to take the Lego system, the material and infrastructure to new areas? And one of them is the Lego Braille brick system. So if you're able to use a Lego system to adapt to Braille, so visually impaired children can use Lego bricks to learn about Braille in more engaging and collaborative ways, then we are able to develop a community of organizations who can scale the training of these activities. So there's now a Lego Braille brick community online where you can work with local community organizations and have training in that system. So taking and adapting the infrastructure and the fabrication of the Lego brick to a system for visual impairment. I would also say that most of our international programs now, given they have inclusion in mind, is a lot about partnerships. So we always partner with health professionals in the local communities because we can get our educational activities and our training and materials out there, but we can't do that without having the full service partnerships in place. We are also now supporting the construction of a completely new hospital in Denmark, particularly focused on chronically ill children, where play is completely integrated. And the reason for that is that children are still children, even if they're chronically ill. They should still participate, still play, keep learning, and keep being connected to the surrounding world. So now, in this new hospital, we are partnering with research and the hospital staff, obviously, to equip it so we can meet any child where they are. If you speak about logic model, for us, the logic starts with humanity, that it is a basic right to play and to learn for the good life, for well-being, to engage with others, but in particular to be a lifelong learner. And for us, it's not necessarily assistive technologies in terms of the size of the market in the beginning, but we figured out that if we can address the most complex needs, then we can also find solutions to change the full system to be more inclusive. When we started thinking about inclusion and interviewing our partners, they say you can't start with everyone. You have to find the ones who have the most difficult needs. And if we're able to work and innovate with them, actually we are able to convince the systems not only from a budget, financing and legislative perspective, but role model and get ideas for how you address other areas. So it is a lever for systems change in our work. And that's the final example I'll be giving. We last year launched a Play for All accelerator program. So that's a program where we look at using play to open up for a bigger diversity of solutions, starting with neurodivergent children. So we support social entrepreneurs to scale their solutions, working with the community. And now there's both examples and websites and local community organizations that are supporting autistic children and ADHD and a growing area in this work. So we feel this is a very important area. It's critical for the future generations. It's critical because the complex needs everywhere, but it also helps us to change the full system.
Thank you, Bo. And simple, specific question: do you support the AT-Scale partnership or other groups like that as well, which are doing market shaping and market shortcoming improvement in AT?
Not at this point yet, but very likely now when we are in the next phase of work, that could be the next phase.
Okay, thank you, Bo, and thanks for all that the LEGO Foundation does, including not just in AT, but also in education. We're going to go to Michael Stein. Michael, you've worked extensively on disability, human rights, but also in a way making us understand that it's not just about having a product. It's not a medical technology, it's a social thing that we need if we really want to fix the AT problem. So in thinking about the medical component of AT and the social component of AT, how do you think we should frame the problem? One version of this narrative can be similar to the way we think about other medical technology. We have cost effectiveness, which do health technology assessment. We bring monies, we create pooling infrastructure. That's for medical technology. We can put AT in that bucket, but like Pascal said, like you've written about, it's a bigger social, cultural issue as well. So how should we frame it in your opinion?
Well, thank you for having me, and I apologize for my voice. And it's been a pleasure listening to my co-panelists because we're all looking and desiring many of the same issues, but from very different perspectives. So I've learned from that. Thank you. And the crucial issues, of course, are even, as you say, if we fix the model, and in the model, there's tension between positively going forward, the increasing population of elders, increasing the market and those who will be in need of AT, and the desire and the incentive by global North manufacturers to have the highest price, highest sort of technology in order to increase their profit margin on it. And as you say, this is something that I take quite personally because as someone who uses a wheelchair and is a human rights lawyer and a public health individual, and who's worked in over 40 countries on the ground, I encounter and am humbled by the persons with diverse disabilities who are handicapped, and I use the word intentionally and provocatively, by lack of AT. So, people who might have a very similar diagnoses to mine, but are on skateboards, or who have to drag themselves on the ground and so forth. So it's a very profound one, but I'd like to be a little provocative again and back up and note that the development of the technology and the medical devices, all of which are important. I would never belittle that, just as when we negotiated the UN Disability Treaty, I was very careful of some of my peers who were belittling the role of rehabilitation and transfers of medical and other technologies. But it has to be done, I think, in conjunction with the targeted beneficiaries, and Bo touched upon that a little bit. It's too often done for them without their input, and the results are often devices that are either less than efficient or perhaps even not really functional. It's kind of the same problem in parallel that we see that plagues many development schemes and also ITC sharing efforts. It's all global north to global south, and it's what we've developed. And here you go, and good luck to you. Conversely, so to put it most simply, there are certain donors, we won't name them, who love to ship crates of wheelchairs, and that's really important. And I'm often asked by ministers in low and middle income countries how they can get them. But when they arrive without spare parts and tools and the knowledge to maintain the devices, they don't exist. They don't help. Conversely, there are many good practices, including those from the global south, that are more resource appropriate, culturally appropriate. So, for example, solar-powered hearing aids where rural communities are off the electric grid, or the prosthetic factories developed with the communities in Da Nang in Vietnam, or the dollar a pair eyeglasses, and so on. In the wheelchair world, of course, to go back to that example, there are inexpensive, locally sourced, and maintainable chairs that do a world of good. John Lazar and I tried to highlight some of these good practices for ITC and AT in our book last year, Accessible Technology in the Developing World. But it's really important to recognize that Global South innovation, because it's their lives and it's their funds, of which they don't have many, and they can't really afford to waste money in coming up with innovations. And therefore, it's important to work in conjunction and in response to them. However, more to your question, the tools, medical, technological, etc., are only as effective as the people and the societies that engage them. And so it's really important to see AT and other things as including and helping everyone, with disability being one of many factors that ought to be included. Many AT devices over the years have been developed to aid persons with disabilities and then have been easily incorporated into mainstream use. And this ranges from typewriters, which some of the audience will be too young to remember, to email, to text to voice, to captioning, and so on. So it's both ironic as well as illustrative of the continuing prejudice towards the disability sector that there continues to be this need to try to justify from the beginning their inclusion, as opposed to seeing the sector as part of the world, 15% of the global population. And it's also important to acknowledge that making AT universally accessible from the design stage reduces the need to retrofit and to make exceptions and to justify inclusion of the sector afterwards. That has to do with design flaws if we're putting things in economic terms.
Thank you, Michael. Very helpful for us to understand a wider context. Next, we're going to go to Andrea. Michael brought this up, cost effectiveness, who pays, and we all acknowledge that the fiscal space for health across low and middle income countries, this is a topic of common discussion here at CGD. What can we do to find more in this macroeconomic environment? You work a lot in health financing. Do you see a place where country governments would be willing to take a much more expansive view of AT, or at least select components of AT, if the cost effectiveness was proven, if we made the case stronger? Or do you think it has to be through some kind of a subsidy or a philanthropy model?
Yeah, I got to go to the end, but I got to answer the difficult questions. So thanks so much for having me. And I've learned a lot already just by listening to the various panelists as well. So thank you for that. So let me take a step back and try to paint a little bit, again, repaint that picture that Pascal started to paint, where we need flexible and pooled resources. And as been mentioned, we don't just need resources for the technologies and the devices, but we need it in order to increase absorptive capacity for human resources to support and maintain those devices and so on and so forth. And then also, it is always more expensive to close the equity gap or to address inequities. So to reach the most vulnerable, those in most the rural settings, the most deprived, is always going to be more expensive. So when we talk about these numbers of cost effectiveness of the 1 to 9 returns, we also have to be very conscious of the context in which we use those numbers, because the cost effectiveness for vaccine interventions is way higher than a 1 to 9 return, which is great, which means you can get more health for your money, but at the same time, that shouldn't come at the expense of others who are just as much in need. So I think, and then we are faced with the issue of the fiscal space that is, and countries, especially in the global south, tightening their health budget, tightening their belts because their economies aren't growing as fast. So there's so much fiscal pressure. So we have to understand what's these various contexts. So what is one to do, right? So I think looking at efficiency gains within the health sector, and Christopher basically alluded to that already in terms of how are countries setting priorities. And in 2023, we have the next UN high-level meeting on universal health care, and really investigate how can the argument for integration of more support, financial support for assistive technologies, both from donors and from country governments, be made. So in the universal healthcare framework, they are basically funded and supported and integrated. From a donor perspective, I love the fact that you mentioned, I call it the BBM, the big bold move that is needed. And maybe we have to, I wish it would be solvable with Lego bricks to get a big bold move together globally. But we're, as you mentioned, in an early immature market, and we're also in an immature stage in the development community, understanding the technical needs as well as the financial needs for assistive technology scale up. And what that means is there needs to be donor money or first loss capital, and those returns that we're used to see and those impacts that we're used to see in malaria and HIV, in maternal child health, in COVID, they will take time. So we need to collectively advocate more from a solidarity and human rights perspective rather than from an economic perspective. Never mind that I'm a health economist myself, but there's a time and a place for an economic argument. And I think that just some of the thoughts that I've had in preparing for today in terms of either structured funds or assistive technology funds, maybe we can learn from vaccine funds in terms of maybe there's earmarked taxation. I don't always like to give that example, but maybe that might be a space. Or outcomes-based financing. We have very few models for outcomes-based financing where the government over time buys into it and the private sector first supports it. Maybe that could be a way to look into this, and then also like revenue sharing models as well. And there have been examples where giving the free eyeglasses weren't always the answers, but actually having a copay for those who can pay, but that then can offset some of the technical assistance work that is needed. So I'm afraid I cannot give you a specific answer. Should it be donors? Should it be governments? I think we need to work together. We need to look for efficiencies and integration into the budget prioritization process, and then to see whether there are some sort of partial revenue models that could then offset the money that is needed. But yes, there needs to be concessional funding. We need to fund if we believe that this is something that there's a right and it's a public good. First and foremost, we need to prime the pump first.
Thanks. Thank you, Andrea. I think the point comes out very clearly here that there are many areas in health which are seeking the use of new instruments, whether it is development impact bonds or other kinds of concessional capital. So it's a competitive market. For AT to compete in that, it needs very clear cost effectiveness numbers. And I think the more I looked into it as I read your documents and all the material, made me feel if we only use the metrics of DALYs averted, then we are losing the social part. So we need a different way of capturing value because there are so many other social and economic aspects that are not typically captured in a more standard sort of mainstream DALY calculation. And that's the only way to be competing in this market for many other health priorities, which are equally important and have immense interest amongst country-level health makers. So anyway, so that's an area for we all to think collectively about how to get to that, and if that is feasible. But in the remaining 7 or 10 minutes, let me go to the audience and ask if people have questions. So let's start with those of us who are here in the room, in person, and then we'll go to Ni. Yeah. And if you would introduce yourself so we know.
Good morning, my name is Neeson. Hello? Okay. Good morning, my name is Nee Simmons. I'm a non-resident fellow here at Center for Global Development. Thank you guys all for your input. I think one of the comments Michael had made in terms of recognizing the need of importing products from the global south, global north, or other more developed countries to underground, and having things, be repaired or maintained. We all know those are an issue. One of the things that I don't think has been discussed here is, what do you guys think about the maker spaces or hacker labs across the world? I'm Ghanaian. I used to work at the World Bank, and my old group, I think they still fund us through a couple of donor countries. We were given funding as my previous role at the World Bank to groups who have or incubators, accelerator programs in some of these markets to develop innovative solutions for local markets. And on one of my missions, I noticed that that you see this all over the continent, but in Cote d'Ivoire, and especially in Ghana, you see these spaces where people are hacking, they're putting together these, refurbished equipment, that sort of thing. And they're making things work. It's not pretty, but if you need a wheelchair, you need those type of things, somebody can make it. So how important is it for these hacker labs, these spaces where it's not pretty, but if you want something, you can go there and get it, and it's really at a percentage of what you will get here in the West?
Thank you, Nee. We'll have one more question that'll give us, the panelists, a chance to think about their responses. Javier.
Javier Guzman from the Center for Global Development. Thank you very much for the panel and for the comments. I think it's very enlightening and interesting. I've got 2 comments/questions. The first one is, when you talk about assistive technologies, it seems to me that it's a very heterogeneous universe, and that is problematic, because if you just go and say it's the same 1 to 9 same glasses than wheelchairs. I mean, I just have difficulty wrapping my head around it. So what are the key, most important 3 or 4 best buys or technologies that we could actually focus on in terms of what the case is and what the solutions are? And the second comment / question is, clearly, as Prashant said, I would agree, there's no way, and you also said it, there's no way you can actually make the argument on efficiency grounds, because clearly the methodology, the cost effectiveness methodology is to capture individual benefit in relation mainly to mortality as well as morbidity, of course. But what about, creating a new methodology to look at, the externalities and the, other benefits, not just to the patient, but to the carer, to the society, to the, to the economy as well. Has there been any work on that, or has there been any thought about doing that? Thanks.
Okay, so we only have time to take those 2 questions. If our audience who has joined us online have questions, we'll do our best to make sure we reply back to you online. So makerspaces, excellent idea, Annie. Who wants to start? Pascal?
Sure, I'm happy to just answer that quickly. I think, yes, indeed, that exists in many places, and they do provide some solutions. I see that more, though, as a stopgap measure and a reaction to the fact that there is no system that's functioning, right? It shouldn't be that we have to depend on these kinds of things to provide the solutions, because they cannot go to scale. They often don't come with the right support structures around it. As we've talked about today, it's not only about the product, it's all the services that go around it that is needed. Otherwise, sometimes you can do more harm than good. And there are still quality issues. I mean, people sometimes think, oh, it's simple, a wheelchair, there you go. But actually, it needs to be individually fitted, and it does require some degree of expertise. So I think, yes, those are good, but I think, it shouldn't be also seen as an excuse for then governments and others not to do anything, because they think, oh, okay, this is taken care of, they'll find their own solution, right? So I think it's quite a tricky sort of.
I have a different viewpoint on this, but we won't get deeper into it. I'll come back to you, Nee, with some ideas on makerspaces, unless if Christopher or Bo want to have a quick response to the makerspaces question, and then we'll go to Javier's question. Yes, Bo.
I completely agree with what was said, that we are supporting this in places like Rwanda and Brazil and Colombia by having partnerships with local makerspaces and international partners. We have a challenge. We can't depend on it because it's not stable hardware. It's not enough manufacturing capabilities. Repairing and recycling is difficult. But I don't think that's why we do it. We do it because it contributes to solutions. It creates some kind of hope and agency for local solutions. And then it's most important, it builds expertise. So it's part of the ecosystem of solutions, even if it's not the end solution. So I think they're very important, but not necessarily as a reliable long-term solution.
Exactly.
Yeah. Do you want to talk about the makerspaces, Andrea, or the second one? Okay. So we'll start with you and then go to Pascal.
Okay. Yeah. So on the question around, is a cost effectiveness the appropriate measure? And the thing that we've looked at in the health space is in health economics is basically the indirect costs or the indirect benefits that follows the impact of an intervention, right? And basically what's the impact on presenteeism, absenteeism, workforce productivity, being able to be a productive member of society. So there are some methodologies that already integrate, analyses, types of analysis that integrate that indirect benefit. And we have, for example, the best buys in the chronic disease space. Now, the issue with these measuring the indirect benefits and then making an argument so people will spring into action is that these benefits are often very diffuse, right? So who pays and who benefits from it is often very distant in this type of methodology. So, and in addition to the methodology, we would have to think about how can these results then be accepted and be acted upon. And I think that's going to be the bigger challenge.
Yeah, I think the key point here is that there needs to be more work to figure this out. I think if we all creatively put our heads together, there can be a way of measuring these diffuse benefits, at least bringing them to the best extent. Yes, some challenges will remain. Pascal, if you can highlight out of the heterogeneous universe of AT, are there things that stand out?
Honestly, it's difficult in this space to really pinpoint. Okay, this is the best buy. I mean, we know what where the biggest needs may be, and that's where we've prioritized the products that AT Scale focuses on initially. So wheelchairs, eyeglasses, prosthetics, hearing aids, digital devices. These are, if you look across the whole spectrum of assistive technology, these are the ones where we felt there was the biggest need and the highest potential to have solutions to make sure that the majority of people who actually need it will be able to access it, right? There are other assistive technologies that are more complex that we also want to tackle and look into, but maybe that'll come as a second order. But like has been said, I think it's really a tricky space to really try to nail down hard numbers. The investment case that we've developed, which is available on our website, that demonstrates the 9-to-1 return, is actually built on 4 AT products, right? So it's eyeglasses, hearing aids, wheelchairs, and prosthetics, and it does include assumptions around the positive externalities that when a child has now eyeglasses, what that implies for that child's life, and employment opportunities, and therefore the return on society and the country and so forth. So we've done that analysis, but as Prashant said, I think it requires still a lot more digging into and work.
Okay, we are out of time. So here's what I'm going to do. We'll go to Christoph, who has his hand. He wants to respond to it. But Christoph, what we're doing is we're asking each panelist 10 seconds, one thing that stands out that we should be doing as we look at this after the session. So I'll start with Christoph.
Be pragmatic in seeing what's possible and documenting that through real life pilots.
Okay, Michael.
Rethinking the models so that we're no longer tethered to traditional, sometimes effective models of profit on the one hand and distribution on the other, and rethinking how we can get to win-win versions and win-win versions that rely upon local stakeholders who have their investments and their agency in seeking good outcomes.
Thanks. Bo.
I think the mindset and the stigma and the raising awareness is the most important. So don't be afraid to get started and engaging with the most complex needs.
Wonderful. Andrea.
I think keep advocating and raising awareness.
Pascal, you get the last word.
More money. Bring in the money. No, seriously, it's not right that we're saying or we hear, oh, sorry, we can't support this because there's a war in Ukraine or there's this happening there or that. We live in a world where there is enough resources to be able to tackle all of these issues, and we should be doing that, and we shouldn't accept any excuses.
Okay. Thank you, everyone. We're out of time. This was a great discussion. Thank you to our panelists. Thank you for coming. And thank you to all our participants. We'll make sure if they have questions, we'll try to respond back. Thanks again.
Thank you.